It's my pleasure now to introduce Mark Carrozza, Health Informatics Developer of HealthLandscape, and Andrew Bazemore, the Medical Director, American Academy of Family Physicians, the Robert Graham Center, to present HealthLandscape's Community Indicators Data Portal. Welcome, gentlemen.
Good morning. I'm Mark Carrozza. I have to tell you, I'm a little daunted here. Normally when I do a data presentation to data people, it's like I'm speaking to the choir. This is a huge choir, and we've got all the choir directors up front, so this is something. So this morning we're going to talk about HealthLandscape, and we're going to introduce to you our new Community Indicators Data Portal. HealthLandscape is a partnership of the Health Foundation of Greater Cincinnati and the Robert Graham Center here in Washington, D.C. We have been developing web-based applications since 2005, looking at things like demographic and economic indicators, looking at social determinants of health, looking at healthcare workforce, and even doing a good bit of work with clinical practices and clinical data. What I'm going to do is I'm going to show you how we're using the Community Data Portal in Cincinnati for a group of funders there, and then Andrew will come up and show how it's being used by a coalition of health centers in North Carolina to look at patient outcomes. So what we're doing in Cincinnati, there are a group of major funders, the United Way of Greater Cincinnati, the Greater Cincinnati Foundation, the Health Foundation, and some others who have been working on bold goals for the city, for the region, where they're looking at education, they're looking at health, they're looking at income, and trying to pool resources and pool efforts so that there's a common agenda, a common work being done across all the different agencies. And when you do something like that, when you have a common impact and a common agenda, you have to have some sort of indicators report. And what happens in any big city like this is you end up with this. You end up with a big stack of reports. Everybody's publishing their own report. Everybody's measuring infant mortality. Everybody's measuring poverty. Everybody's measuring the same thing. And it's great business because they pay me to do it, but it's just not useful for the community. So what we've done is we've created a data portal called Facts Matter. And actually, that's a website that merely maintains the Community Indicators Data Portal application. What you see sort of below the Facts Matters branding is the actual HealthLandscape Community Data Portal. And what this is a very customizable Flash application that sets on another organization's browser. They have complete control over the design, complete control over the data that has been deployed, complete control over text. Everything's managed by the users at a United Way or Chamber or any of the other organizations. Actually, in Cincinnati, there's a group of probably 7 individuals from 7 organizations that meet regularly to decide, what is our core indicator of associate's degree? What is our core indicator of infant mortality? So what I'm going to do is show you one of the bold goals in Cincinnati, which is access to care. Having one of the Healthy People 2020 goals is having 95% of the population having a usual source of care. So what we'll do is we'll go find that data. Just to give you some of the feel for what else is available in the portal, the committee has put in population data, so you have population change, Hispanic population, net migration, adolescent data, including low birth weight, infant mortality, any number of academic indicators. In the world of health, there are chronic conditions and health-related data. And again, a lot of this is local data. Some of it we're pulling from CDC, Census Bureau, what have you. A lot of this is from our own local surveys, so we can create a mix that tells the most appropriate story. So what I'm going to do is go down here and look at our usual source of care item. Usual source of care is proportion of adults in Cincinnati who have a particular doctor where they go to when they're sick. So we'll go ahead and turn that on. We see a nice map of the region. And typically when you're working with this type of data, this data nationally comes from Burfus or some other data sets where you've got national or state level data only. But because locally we have very local data, we're able to deploy the data in this portal. So I'm going to mouse over, show you some of the areas, Cincinnati, the rest of Hamilton County. We have the ability in the tool to show data tables that match the data that you're seeing, charting, bar charts, graphs. And again, the user has complete control over what they see. The people who are deploying the data have complete control over what's deployed. Finally, I want to show you one little slick little tool that we like, which is our thematic slider. I'm going to show you poverty level data by census tract for the region. Yes, I am. Okay. And again, it's a mapping application, so you can go in and change the colors, you can go in and change the number of categories and all those things. But what we want to do in Cincinnati is we want to target a specific area. We have our place matters areas where we're really focusing money, focusing attention, focusing effort. So I'm going to zoom into the central area of the town. I'll use our threshold tool to set a threshold of, let's say, 20% or 30% poverty. And now we can start to see exactly where there's high levels of poverty in the region. We can go into our base maps and turn in some of our neighborhoods so we can see where specific neighborhoods in the regions are compared to high levels of poverty, compared to infant mortality, what have you. So what I'm going to do now is turn this over to Andrew Bazemore, who's going to jump in and talk about how they're using the portal in North Carolina for patient outcomes.
With that step, I really feel like I tower. Andrew Bazemore, the medical director of the Robert Graham Center, very interested for years, and through this project with Mark, have been able to take work that we do, analytic work, to try to drive community health forward, and through HealthLandscape find a platform where we can actually engage stakeholders, help them make decisions. And we get really excited at where we sit in 2012 at the capacity to help these communities of solution form by finally being able to achieve the holy grail of intersecting social determinants, population health data, and clinical information. We also get really excited when we can truly engage the stakeholder. In this particular case, in Community Care of North Carolina, an innovative provider of Medicaid services, which has reduced the state budget for Medicaid by as much as $250 million per year, partnering with the Beacon Group, also federally funded to bring health innovations to the southern Piedmont, have brought in the Graham Center, as well as HealthLandscape, to help build the North Carolina Public Health Information Data Portal. And we really see that intersection as the fertile ground for driving community change. If you can imagine for a moment the conversations we've been able to have in this only 6-month-old project, and what I'm going to show you is very much in beta, where you come to the table and say, you know, I've got my state Medicaid director, I've got the Office of Rural Health present, I've got folks from the local health departments, policy and decision makers from across the state sitting down, and they just want to start with a simple question. Where are my health care costs in North Carolina the greatest per month for Medicaid? It's killing our budget, and I need to be able to go in and look and see whether or not I can actually identify outliers, variants. And so I suddenly pull up Appalachia, a region I've long been concerned with, and I see instantly that Buncombe County, that many of my western states around Asheville, North Carolina, seem to have a particular preponderance for high Medicaid costs per month. But the real excitement comes when you're able to go back and say, you know, I'd like to start to explore why. Could it be that the Medicaid population reflects an increasing Hispanic community, African American community, female community? It certainly doesn't look like it right now, although Hendersonville and Henderson County may actually give us pause to consider and look a little further. Could it be that it's an access question? If I go in and I take a look at Medicaid enrollment, I'm actually looking at a real problem with some of the practices, and I should add that this brings together every single Medicaid provider in the state and practice level information, which I'm not allowed in this forum to roll over and show you yet. But imagine if I could, starting to look for clusters and actual practice level information for quality indicators, and in this case, the degree to which they're burdened by dual eligibles for Medicaid and Medicare services, which we know drive up cost. Could it be that it's, again, a problem for a certain disease, and the disease management services that have been the key to community care's cost reduction perhaps not being delivered? So you start to look at asthma services by county. Do I actually want to start to look at disease management outcomes? And whether I look at asthma, diabetes, cardiovascular conditions, or many others, I can separate them by county or even down to practice level. I can even begin to go and split my screens at a secondary indicator. So if I go back to healthcare costs, I can pull up on one screen my average monthly total Medicaid services up against asthma and continuing care assessments. Perhaps I want to go and look at prevention services, cancer screening, dental care, pediatric prevention, disease burden, either for the Medicaid or the general population. I want to reveal perhaps that if I go and look at COPD, given the smoking preponderance in the western part of the state, that I have a real problem for my counties in COPD or pulmonary disease, emphysema, and again, other pulmonary disease. Perhaps it's the hospital utilization that's driving my problem. And I want to go and look at emergency department visits and compare parts of the states with my asthma by county visits. In any event, I'm able to bring these stakeholders together and have real conversations because I finally achieved something that in the last great generational healthcare reform we didn't have in 1967, the capacity to truly integrate public health, primary care, and communities by bringing together the social determinants and the clinical information they need to decide them. We look forward to driving this project forward and to seeing you out in the lobby as well. Thanks so much.